Today we're going to talk about neuromuscular blocking agents and neuromuscular nerve stimulators for monitoring those blocking agents. And basically, this is a presentation that I did to anesthesia techs at an anesthesia tech meeting, but there's a little thing here, anesthesia in the old days, hitting the patient with a rock, but basically anesthesia in the last 40 years has changed a lot, so we're going to talk about some of those changes. Speaking of the 1800s, there was a drug discovered that the South American natives were using called curare. And curare was the first paralytic, the first natural occurring paralytic. And from curare, everything has been developed with regards to synthetic drugs. But curare was the first drug that would actually paralyze someone yet not put them to sleep necessarily. And they would use it for hunting. They would hit a mammal, and the mammal would run off and then collapse, and they would be able to retrieve it. So curare was one of the first drugs, first recorded in the 1500s by explorers, first used in anesthesia in 1942. So that's not long ago. And then we came out with a drug called Sux in 1949, and then they came out with these synthetic drugs, and rocuronium is currently the paralytic that's being used most often. Now, why do we use paralytics in the operating room? Basically, prior to paralytics, you couldn't even put an endotracheal tube in somebody, so they used mask anesthesia a lot. So really, neuromuscular blocking agents literally revolutionized the practice of anesthesia. They used to have to breathe people down with masks and with anesthetic agents, and that's the way they did it. And they had to put them so far under with the anesthetic agents that they could do the operating of the patient. But that depth was so deep, it caused other problems. So they introduced curare and then these other drugs such as rocuronium that would literally paralyze the patient, and it would allow them to paralyze their vocal cords so that they could pass an endotracheal tube through the vocal cords without the patient going into a laryngeal spasm, if you will. So before neuromuscular blocking agents, anesthesia was induced with inhalation agents to the point of cardiac depression and respiratory depression. Tracheal intubation was uncommon. Then we came out with neuromuscular blocking agents, and anesthesia became kind of a triad or a three-legged stool of muscle relaxation, which is the paralytic, analgesia, which is the pain, and then narcosis, which is the sleep medicine, such as propofol now being used. So tracheal intubation became a common practice once we introduced neuromuscular blocking agents. But in the scheme of things, it's been relatively recent. One of the things that are concerning about neuromuscular blocking agents is the fact that you can have a residual neuromuscular block on board. So when you go to take a patient from the operating room to recovery, if they don't respond well, it could be because too much anesthetic was given, could be because too much analgesia or pain medicine or opiates were given, or it could be that there's a residual neuromuscular blocking agent still on board. And a result is you have post-operative residual curare effect, or PORC. So these are things that they're concerned about. The worst thing you could ever happen in an operating room or actually in a recovery room is have to re-intubate a patient. So residual neuromuscular block is defined as a train of 4 ratio of less than 0.9 or 90%. And it happens fairly often. So the effects of a residual neuromuscular block is residual paralysis. If you've just had surgery, you cannot believe how uncomfortable it is to be not able to lift your diaphragm to breathe, yet you're awake. And that's what it's like. It's almost like a suffocation feeling. Your saturation will drop because you're not getting deep breaths. And they have to respond to basically save you. So obviously you get poor sedation scores, you get poor scores for if the patient's having that experience. There's all kinds of things that can happen that are airway collapse, aspiration. In other words, they might vomit and then aspirate it. So neuromuscular blocking agents and the residual neuromuscular block is a big deal they want to avoid. Neostigmine is a reversal, and so is sugammadex. Sugammadex is brand new. Neostigmine has been used for a long time, but basically once you give rocuronium, and typically in an anesthetic, they'll give rocuronium right before they're going to intubate the patient. So they'll give propofol, then they'll get all ready to intubate. They'll give rocuronium or SUX, which is the paralytics. They'll wait a minute or two. They may use our device to see when they're completely paralyzed, and then they'll pass the endotracheal tube through them. Then they'll go through the entire case, giving more rocuronium if it's a long case, and then as the case gets to be finished, they'll give neostigmine to reverse it, or they'll give sugamidex to reverse it. But basically, these are two reversal agents. You can have critical respiratory events. In fact, basically, reintubating a patient in the PACU is really a bad thing, and the goal is to know where your patient is. So if you know your patient has a train of 4 of 90%, you know they're safe to extubate, and that's what the train of 4 monitor, the Stimpod 450, does. It will let them know quantitatively where they are at. Here's some studies of 18,000 surgical patients. 151 had to be reintubated. That's a terrible thing. 5% had saturation that dropped below 90. 1% had saturation below 80%, which is bad. 55 actually died in the hospital as a result maybe of brain damage or oxygen, being deprived of oxygen because they're not breathing because they're still paralyzed. So qualitative monitoring using a peripheral nerve stimulator of neuromuscular transmission did not decrease the risk of a post-op respiratory complications. So even though patients or providers, anesthesia providers, were using peripheral nerve stimulators to clinically look and subjectively look for a train of 4, it did not reduce the occurrences of problems. Neostigmine reversal increased the risk of postoperative desaturation less than 90% in reintubation. So what that means is neostigmine sometimes is a reversal agent, and it will, if you give a reversal agent to a patient that doesn't need to be reversed, that can also cause problems. So the important thing is to understand that paralyzing a patient is needed in anesthesia, but it is also requires responsibility. So, for example, here's ratios were all calculated years and years ago using a mechanical method all in research. So we have these ratios and these percentages, but it has only been until recently when we've had a quantitative device that can actually reliably give us these percentages. But basically, if you have a patient that has a train of 4 ratio that is 50% or lower, then that means they would be impaired for swallowing, their upper airway would be impaired. They'd have really problems if you took out the endotracheal tube. It's not until they're 90% or above that their swallowing and everything else is not impaired. So what we're looking for with train of 4 is you're actually stimulating the ulnar nerve 4 times, and they're observing these 4 twitches, and they're trying to make a judgment between the first twitch and the last twitch, and they're trying to subjectively make a comparison between the last twitch compared to the first twitch, and it's been proven relatively impossible. So what does a nerve stimulator do? Even though the peripheral nerve stimulators all have these capabilities, and twitch is just one stimulation, tetanus is a continuous rapid stimulation of either 50 or 100 hertz. It's kind of painful if you're not asleep. Train of 4 is what we're going to focus on, and it's 4 of these twitches with a 500 milliseconds apart. Double burst is another way of looking at paralytics, and post-tectonic count is used when a patient is showing 0 stimulations on train of 4, and the clinician wants to know how deep. So there's occasions when a surgeon really wants the patient to be totally paralyzed, and that's when they would give them extra rocuronium, and they would maybe use the testing system of post-tectonic count. It delivers tetanus for 5 seconds and then delivers 20 twitches. Our monitor actually counts those for you, but otherwise they just have to manually look at it and count them themselves. So a train of 4 ratio, once again, is the device stimulating the patient 4 times, and if you get 0 of 4, that means the patient is paralyzed. If you get 1 of 4, that means they're starting to come back from their paralytic. 2 of 4, 3 of 4, and 4 of 4. Once you get to 4 of 4, that's when you start seeing percentages on our device. Once again, if you're using a peripheral nerve stimulator, you never see percentages because you're having to qualitatively make those judgments. Train of 4 percentages, what do they mean? Once again, a patient that is less than 90%, the patient needs to be needs time or needs reversal agent before you extubate. And by the way, all anesthesia providers know these guidelines. Greater than 90%, that patient is safe to extubate with little worry of post-operative residual curare effect. Studies show that no anesthesia clinician can subjectively tell the difference between 40 and 90% in a reliable basis. I think they did a study of 12 experienced clinicians, and only 1 was lucky enough to be able to tell the different percentages. So they really do need a quantitative method of determining the level of paralytic. So quantitative train of 4 monitoring is endorsed by the Anesthesia Patient Safety Foundation and by the International Association of Research Society, Anesthesia Research Society. We have those documents to share with you. So really right now what they're doing with peripheral nerve stimulation is they're literally like lost, because if it's a long procedure, they kind of lose where they are with regards to the paralytic. They look at the, especially when the patient is being revived from their anesthesia. So even with a peripheral nerve stimulator, we can see 0 of 4, so we know the patient is paralyzed. But as they're coming off of that paralytic and we're trying to decide whether to extubate them or not, and if it's safe to do that, with peripheral nerve stimulators in subjective train of 4, they really have no idea where they are. So subjective versus objective, that's the new thing, is objective train of 4 monitoring or quantitative train of 4 monitoring. And there's several methods out there. There's a mechanical, that is where all the percentages came from the research, but it's not conducive to the operating room. There's something called Keenum Iographer, which GE has, but it's an option that is incorporated into their monitor. I'll show you an example of that in a moment. Then there are the basic peripheral nerve stimulators. There's LifeTech, used to be the company, was bought by Halyard. They make the mini stem and the easy stem. I think these are actually discontinued. SunStem makes a peripheral nerve stimulator. They make the SunStem and the SunStem Plus. B. Braun does nerve location, so they don't have a train of 4 monitor. Anesthesia Associates has one. Neurotechnology used to make several, and they're closed. So really the places you can get them, and we sell SunMed and we also sell LifeTech. So if a customer really wants a subjective train of 4 nerve stimulator, we can provide that to them. So here's the qualitative or subjective devices. They usually have electrode balls on them so that you can place these electrodes on the temple or on the ulnar nerve, which is down on the wrist. And they would press either, train of 4, perhaps. There's a train of 4 there. Train of 4. This device is no longer available. This device here is still available, and these are from SunStem. They are available. This shows the GE Keenum Iographer. Basically, it's a mechanical method. So they put the electrodes on the ulnar nerve, and they're looking for thumb movement, and they put this kind of banana plastic device there, and that compression, when they stimulate it, the thumb moves, is registered on the device and on the monitor. The main advantage of this is that it's connected to a monitor, so if it's connected to an electronic medical record, it's passed on, and they can actually view a bar graph or a waveform on the display. The disadvantage of it is this technology is not as accurate as our accelerometry or other technologies. Quantitative or objective train of 4, there used to be a device called the Toff Watch. It used a single dimensional accelerometer, so the device had to be calibrated for each patient. It still worked off the ulnar nerve. It is no longer available. It was discontinued about 2 years ago. So for the last 2 years, the only handheld standalone device that is available for quantitative train of 4 monitoring is the Zavant Stimpod. This shows electrodes on the ulnar nerve and our accelerometer, and shows that this particular patient is 93%, so they would be safe to extubate. So accelerometry on the Stimpod NMS 450 is advanced technology. It is three-dimensional accelerometry. There's no need for doing a baseline for calibration. However, clinicians will still do a baseline. What a baseline means, they don't always do it, but they can. What a baseline means, it means you're putting the electrodes on the ulnar nerve and you stimulate and you're looking for good thumb movement. So it verifies that they have the electrodes in the right place and the patient's responding and they have the correct current delivering them. But because ours is three-dimensional, so that baseline tells them some things, and they can do that with ours also, but previous devices like the Talk Watch, you actually had to set it up and tell it this is 0 and this, and you had to calibrate it. Whereas ours, because of the three-dimensional accelerometer, there's no need for a calibration. So it's easy, quick to set up. You could use it in the middle of a case. You can use it at the beginning of a case. You could walk into a room and put it on a patient and it'll work. So there's no calibration to a patient needed. That's why some people use these, recommend having an extra Stimpod, because they can take it to the recovery room and put it on a patient and, once again, not have to calibrate it and be able to tell whether the reason this patient is responding, is it due to residual nerve block, or is it neuromuscular blocking agent, or is it something else. Anatomically, the ideal stimulation site, the #1 site is the ulnar nerve, which is on the wrist. And using the thumb as the measuring device. You can also use the big toe and the ankle nerves, and a distant third and fourth is the facial nerves. The ideal is because it's easy, accessible, and the response is clear and not prone to any problems. This shows the electrodes on the ankle and using the big toe. Sometimes our strap isn't big enough, so you'll have to tape the sensor onto the big toe. We also now have 11.5-foot cables. We didn't have those before, so now those longer cables aid in this kind of technology. Also, monitoring the face is possible, but we don't recommend it. You need to be more precise on putting the electrodes over the different nerves, and sometimes you need to use our nerve location pen to do that. So we recommend using these facial nerves as a distant third and fourth option. But I'm just going to show you using the Stimpod pen to locate the nerves would be the way you would do this, and you would take the strap off of our accelerometer, and you would use ideally double-sided tape. And you can either use it over the eyebrow or over the eyelid. So it is possible, but it's not necessarily the ideal way to reliably do our technology. So we recommend the ulnar nerve and the ankle first, and the facial nerves of distant third and fourth. Troubleshooting on our system, batteries, sometimes people can put in the batteries wrong, and you can turn on the monitor and the monitor will power off after 5 seconds. So if you ever put in new batteries, and you look at the monitor when you power it on, make sure that the battery indicator shows that it's filled in dark, and that means you have the batteries incorrect. Stimulating at 60 milliamps with no relaxant, no contraction. If that's something that occurs, maybe you need to check your electrode placement. Maybe your cable's bad. Maybe the device says open circuit. There's some things there to be concerned about that we'll talk about. Sometimes, though, it's important to know that the patient, you might deliver 60 milliamps and the thumb might not move. Well, the patient may be still paralyzed. So be aware that I've actually seen in an OR where they did the stimulation and they had the accelerometer just hanging from the monitor. It wasn't connected to the patient. They were going, well, why are we getting 0 or 4? Well, they didn't have it connected to the thumb. We do have a removable IV pole mount. So this is an IV pole mount that is attached with electrical ties. It's real easy to put on. It allows it to pivot or actually spin on the IV pole mount, so you can turn it to your direction. It also comes off of this real easy with this clamp, so it allows them to hold it in their hand. So this is the IV pole mount that I recommend. It's only $105. Gives the facility a place to always store the Stimpod along with the cables. They can wrap them around there, and yet when they want to use it, they can hold it in their hands, use it whether they're sitting or standing, and move on. We also have a locking IV pole mount. I personally do not recommend this because it does secure the device, but it eliminates the ability for the user to hold it in their hand and use it or put it closer to the face, that type of thing. But it is an option for some of those teaching institutions that are concerned about theft. We do, as I said, have an 11.5-foot cable, and that improves things for using the ankle, for example. Once again, you want to assure that the electrodes are good because they can dry out. You want to assure that your electrode wires are secure. Batteries must be in correctly, or the unit will power up and then power down, and verify the milliamp set compared to the delivered. So on the display, which I'll show you in a moment, it'll show that the milliamps are set, let's say, at 30, and it delivered 29.5. So right now, a lot of anesthesia providers will actually take a peripheral nerve stimulator, they'll use it, and they're not even sure it even works, so they'll shock themselves. Well, with this device, it actually shows you what milliamps were delivered, so they can look at that. We've got a lot of endorsements: the Anesthesia Patient Safety Foundation, the International Anesthesia Research Society, and the AANA, which is the American Association of Nurse Anesthetists, have all endorsed not only peripheral nerve stimulators, but quantitative. CRNA named Mark Welliver is a proponent of it. He stated there should be a quantitative train of 4 monitor in every OR, but a minimum 1 per hospital. Merck, who makes Sugamidex, also recommends train of 4 monitoring is recommended when you're using their drug. This is the International Anesthesia Research Society consensus statement, and I recommend having this printed out and giving it to anybody, because occasionally you'll ask somebody, you're doing quantitative, or are you familiar with quantitative train of 4 monitoring and nerve stimulation? And they'll say, oh, I don't use nerve stimulation, I reverse everyone. Well, you got to be a little concerned about that provider, but this document actually says that use of peripheral nerve stimulators should be abandoned because they are prone to error, and it's basically endorsing quantitative train of 4 monitoring. So to use statements like are prone to error and should be abandoned is pretty amazing and serious. So they're basically saying that peripheral nerve stimulators should be abandoned because they're prone to error, and you should use a quantitative device such as the Stimpod. They don't name the Stimpod. The Anesthesia Patient Safety Foundation back in 2016 came out with a couple different articles, and we have these all available for you, but basically said, you know, what would you do if you were the patient? What would you expect? And they would expect quantitative train of 4. Once again, knowing where you are with your paralytics. That's just the rest of it. So here's the actual devices that we're going to talk about. There really is 3 different devices that the Zavant makes. One's called the 410, which is for nerve location, which is kind of being shown down there. There's a 450, which is for train of 4, and then there's a 460, which is for pain. But our device, the 450, is $1,265. There's really no reason to discount unless they get into quantities that are 5 and above, and then you'd only discount 5 or 10%. Like I said, this is old. The locking no theft now is $295 because it now pivots and tilts. But the IV pull mount that I recommend is still $105. So, in conclusion, quantitative train of 4 monitoring is available now on the Stimpod 450. It improves patient safety. It assists anesthesia providers in titrating their muscle relaxants, and it helps them with their reversal agents, provide them safely and efficiently. It is an essential part of an ERAS, or enhanced recovery after surgery, because if you have too much paralytics still on board, they're not going to recover well. So it really is a key to allowing your patient to go to the PACU and recover well and not have the risk of residual neuromuscular blocking agent. So that's that presentation. I'm going to close that down, I believe. Let's see. Now, if somebody come off mute, I want to make sure that I'm bigger in my picture and you can see me well. I hope I took away screen sharing and now I'm a bigger.
You look fine.
Okay, good. I look fine. Thank you. Okay. Well, now we're going to do a demonstration of the Stimpod. So basically, one of the things you should be aware of is some of our customers have a black cable. The black cable was a good cable, but it is not as reliable as this gray cable. So a lot of the problems we had over the last 12 months with the Stimpod had to do with cable issues. Well, now we have a cable that is significantly stronger, and that has eliminated a lot of problems. We've also updated the system numerous times in the last 12 months, and now we're at a 9.98, 9.99 software. So when I'm presenting this device, what I would do, first of all, some of the questions you would ask before you even get to showing the device is you would ask, are you familiar with quantitative train of 4 monitoring? Or are you using nerve stimulators to monitor your paralytics? And like I said, most of your clinicians, CRNAs especially, will say yes, because part of the AANA requirement is that if you use a paralytic, you will also use a nerve stimulator to monitor that paralytic. So it's a guideline written in the American Association of Nurse Anesthetists guidelines. The ASA has the American Society of Anesthesiologists has very few written, documented guidelines. One of their few is that they must monitor temperature. But their concern, I think, is that when they say something like you must use a peripheral nerve stimulator, that is if they don't use one and they have it as a guideline in their rules, then they could be sued. So that's why they have fewer and fewer. But the American Association of Nurse Anesthetists recognizes the value of using a peripheral nerve stimulator, and ideally a quantitative one, to measure the paralytics. So when we power the system on, so one of the questions you would ask is, are you familiar with quantitative train of 4 monitoring? And they may say yes, I am, or maybe no, I'm not. And what you want to do is introduce the Stimpod 450 to them. Okay, so when I power it on, it remembers the last milliamps, and in this case, it's measuring 80 milliamps. And you'll get this question often, and I basically just spin this wheel. I'm going to bring this down a little bit. Basically, you spin this wheel, and if I don't press enter after I spin the wheel, it'll go back down to 80. So I'm going to spin this wheel, and I brought it down to 0. But if I don't press the enter key, it'll go back to 80. So once again, I'm going to spin this wheel backwards or counterclockwise. I'm going to lower the milliamps to let's go to 30, and then I'm pressing enter. So now it's locked in at 30 milliamps. When you power up the device, it powers up in train of 4. When I'm doing an in-service, I will show them all the other modes, and I think it's important for you to know that too. So when I press the menu key, it changes the information from train of 4 to dB. That stands for double burst. I press it again, it goes to post-tectonic count, which is where you give that 5 seconds of tetanus, which really grips you down and then gives you 20 twitches. And then I press it again, it goes to twitch, it displays twitch, and I can press the enter key and change that twitch to 5 hertz, 1 hertz, or even 2 hertz. So it pages through different settings. I press it again, it goes to tetanus, and I can deliver it at 50 hertz or 100 hertz. And then once again, if I press it again, it'll go back to train of 4. But in essence, when you power up the device, it powers up to train of 4 mode. Now, what I would do is, if you were doing an evaluation or a demo, you would want to bring electrodes, but also you could just ask them to get electrodes. They have ECG electrodes everywhere, and you would recommend that they would put them on a volunteer or on yourself or on themselves to go through this demonstration. So basically, the ulnar nerve is kind of something you follow the pinky finger, if you will, and you put one electrode, close to the wrist, and the next electrode isn't as critical. It can be really anywhere. And you generally put the black electrode closest to the place you're stimulating, and then you put the red electrode to the next one. So I have the electrodes thus placed. And I'm set at 30 milliamps. So then I would connect my accelerometer, which this is a new cable, so I have to get this out here. I'm going to bring it down here so you see this. Okay, so I'm going to take this, and the nice thing about this accelerometer, because it's three-dimensional, is you can have it on the thumbprint, you could have it on the side, you could have it on the thumbnail. It doesn't really matter as long as you're consistent on that particular patient. So now I'm dialed up to 30 milliamps. So that I have the menu key that goes through all the different options and the enter key, but the middle key of the wheel is where I do my stimulation. So if I press that, you'll see the green light goes on, and you also saw a green light over here go on, and you saw my thumb move. You notice it says that I'm 143%. Well, that tells you a couple things. It tells you that we do not truncate any information. We give you the information that it does. But basically what we're comparing is the fourth twitch to the first twitch. So you can see even in the bar graph, hopefully you can see that, the bar graph actually shows that the fourth twitch was much larger than the first twitch. And the reason that happens with a patient such as myself that's not paralyzed is I know I'm about to zap myself at 30 milliamps. And it really doesn't hurt. It just feels awkward. I'll be able to do better the next time, but usually the first time I kind of stiffen up a little bit, and as a result I don't get as much thumb movement. And then I gradually relax, and by the fourth twitch, I know it's not really hurting me, and that's why the fourth twitch is much higher. Now, in normal anesthesia, you would see the bar graphs be the opposite direction. So you'd see the first twitch would be higher, and then they would gradually trail off. And if you were at 0 of 4, you wouldn't see any twitch. So I'm going to take the accelerometer off, and I'm going to, well, there's a couple ways to do this, but I'm going to twitch. Now, a couple things I'll tell you is you saw my thumb move again, and I would ask anybody if they could tell the difference between the fourth twitch and compare it back to the first twitch. And you virtually cannot do it reliably, so that's why we use the accelerometer. But there we did the stimulation without the accelerometer on, and we got 0 of 4. So this would simulate a patient that was completely paralyzed. You can also do that by bringing the nerve stimulator down to about 5 milliamps. So you make it almost so low that you barely feel it. So I'm going to go down to, let's say, well, we'll go to 5 milliamps. So now I'm at 5 milliamps, and I can do the stimulation, and I barely feel it, and I didn't move, and there's 0 of 4. So there's a couple different ways to demonstrate 0 of 4. But that's showing, if that was on a real patient, that's telling you that that patient is completely paralyzed, and I'm safe to intubate him, and the surgeon's safe to do the surgery and not have any muscles twitching. So I'm going to advance it back up to 30 milliamps and press enter. And, well, I probably could do a couple different things. I'm going to do it one more time, try to relax my hand. And I'm going to press the enter key. So I did the stimulation. That time was 124%. But in essence, normally you would get around 100% if the patient was asleep but not paralyzed. Okay? So there's other thing to be aware of. The reason why we provide you with the bar graphs is if one of the bar graphs was really low or really high in the middle, for example, it would tell that tell the user that maybe there was some artifact there. Maybe the surgeon leaned on the arm as it's being tucked, or somebody bumped into the accelerometer as it's being used. I can also demonstrate if I go down to like 10 milliamps, which is really low. I can make the accelerometer move myself. So if I so there I just did 2, so that shows 2 of 4. If I wanted to maybe show a patient that was having fade, in other words, they're coming back just off of anesthesia, there is some of the things I might point out on the display is, first of all, there's a thing that says what milliamps we have set, and then there's a reading next to this that says 10.0 milliamps approximately. So that's telling you what was delivered. So with this device, you always know what you have it set at and what was actually delivered. So if you do a stimulation and you get 0 of 4, and they're concerned that maybe a stimulation wasn't actually given, they would then look at the display to see, yes, 10 milliamps was actually given. There is also a time period between stimulations. Usually at monitors that we ship off to you, the time period is set at 15 seconds, but you could reduce that if you want, if that's too long while you're doing a presentation, to be able to present it again. So I'm going to do it again. where I moved it, and I got 19% that time. So once again, if I'm in anesthesia and I'm at 0.4, that means the patient's paralyzed. If I get to 2/4, that means things are starting to wear off. And as soon as I get to the fourth twitch, I'm going to see it maybe at 10%. Maybe I'll see it at, in this case, 19%. Gradually, you'll see it, the paralytic wear off. And once you get to 80 or 90%, you know, then you're close to a point where you can extubate the patient and they will be safe and be able to breathe without any residual neuromuscular blocking agent. So as I show this again, I'm going to go back up to 30 milliamps, press enter. Just to show you a few things, if I lose an electrode, like when an electrode doesn't come on, the monitor will say open circuit detected. Now, we got a lot of open circuit detected before when we had a bad cable. So if you had a cable in and they had it securely connected to 2 electrodes and you got this message, it meant your cable was bad. But in this case, I actually had removed my my electrode, so I'm going to connect it again, and then that message probably went away, which it did. Okay. Let's see. So we also, just to tell you, there's a menu key. If I hold the menu key down for a full 1.5 seconds, it will bring up an actual menu that I can page through with the wheel. There's not a whole lot of things you would do here, but there is, for example, a repeat timer for train of 4. So I'm going to press enter for that, and right now it's set at 1 minute and 20 seconds. So 2 minutes basically. And this would be something if you were wanting to monitor your paralytics during induction, you might put this down to 15 seconds. And you'll put it in an automatic mode, which I'll show you in a minute, and every 15 seconds it would do that stimulation. In fact, let's do that. We're going to bring that down to 20 seconds. And I'll press enter. And I confirm and say yes. And then I press the menu key. So now what I'm going to do is I'm going to put it in automatic mode. So to do it in automatic mode, now typically you would do this, like I said, possibly in induction, because you wanted to, you give the rocuronium, and sometimes it takes 2 minutes for that paralytic to set up, and this is a way you can observe it going down. So the patient being paralyzed. So I'm going to press the stimulate button and hold it for a full 1.5 seconds, and that'll put it in automatic mode. So it just gave me a stimulation. I was at 120% because obviously I have no paralytic on board. And then there's a timer clock going. It says 13, 12, 10. So in about 10 seconds, it's going to give me another stimulation. And it'll continue doing that repeatedly until I take the stimulator off automatic mode. Now, they might even set this up at every 15 minutes during maintenance of anesthesia. There's a stimulation again. One of the things I might note to you is that if you get full hand to compress, that's okay, as long as the thumb is moving too. But if you ever put your electrodes on and you just primarily get the baby finger, you really don't have the electrodes located correctly, or you don't have the current up high enough. So that showed 121%. It's going to give me one last stimulation, but I'm going to press the stimulate button and hold it for 2 seconds, and that takes it out of the timer mode. And now it won't stimulate it only unless I press the stimulate button. Okay, so that is the Stimpod 450 quantitative train of 4 monitor with accelerometer. I might mention that the battery cover in the back has 4 AAA batteries, and you got to make sure they have those connected correctly when you change them. It has a clip here that basically allows it to hang on to our IV pole mount, and then it sits nicely on the IV pole mount, and then you lift it off to take it off, and then you're able to adjust it. Okay, that is the presentation I wanted to give, and now I'm going to open it up to questions on the device. So if you would unmute yourself, you're welcome to ask any questions.
Well, Kevin, what's the lifespan of these? How often are they replaced in an acute care setting?
That sounds like Carol in Colorado, and I would say generally these devices should last 5 to 7 years, although technology is changing rapidly. But in the past, nerve stimulators have lasted a pretty long time. But at this time, there is a huge inventory in all your hospitals of old stimulators. And they don't make parts for them anymore, so people are they're having to make a decision all the time to either buy the handheld ones with the little electrodes that are subjective, and those are so small that they easily fall into someone's pocket as they walk out of the OR, and they disappear. So they're constantly reordering those, and I would tell you that, I don't know whether I have my catalog here handy, which I should. Yeah, I do. We have in our catalog, so when you're paging through the catalog, which is what we want you to do to sell everything with Bell Medical, you'll actually come across the other electrodes or the other peripheral nerve stimulators that we sell. So this shows in our catalog the LifeTech nerve stimulator, and then one down here below also. Those are from Halyard now. They're more expensive, but they also are an option. We also have from SunStim or SunMed, and we sell a fair number of these. So we sell a lot of these, and when we sell them, we're okay with selling them, but if you see them on your commission report, you should go to that customer and say, hey, there are other options besides these subjective nerve stimulators. So a lot of these get sold, but the Anesthesia Patient Safety Foundation recommends not using these because they're subjective. The International Anesthesia Research Society says that these are prone to error and should be abandoned. So they're available, and we sell them and people buy them. But when you get to this page on your catalog, when you're paging through it, you would ask your clinician, are you familiar with quantitative train-of-4 monitoring? How do you monitor your paralytics now? And like I said, you'll get some reactions say, oh, I use a nerve stimulator. Some people say, I haven't used a nerve stimulator in 2 years. I just reverse everybody. And part of the reason why they reverse everybody is because they don't know where they are when the case is over. And from a medical legal standpoint, if they took a patient to the recovery room and hadn't reversed them and they had residual neuromuscular blocking agent on board, that would create a potential lawsuit for them. So as a result, they reverse everybody. But the problem with that is if you reverse a patient that is actually at a point where they don't need reversal, they can have the effect of a residual neuromuscular blocking agent on board, so they actually have trouble breathing. So it's better to know where you are, and why not? It's so easy to set up. There's no calibration. It's an easy system. So does that answer your question? I forget.
Yes, thank you.
But they do last, I would say, 5 to 7 years. Now, we are at 9.98 technology right now. We do know that there's going to be some enhancements later on in the year to this that will give them additional capability. So be aware of that. So it's constantly changing. We're going to have an upgrade path for those customers that have bought them. We probably sell 600 to 900 of these a year. We've had recent sales this month in the state of Washington alone. Jim Blor's group sold 21 to a hospital in Spokane, Washington, and sold 14 to a hospital in Bellingham, Washington. And like I said, they're $12.65 each. We don't really need the discount because there's no one that has anything like this. Although there is a company called that has it's not a handheld like this, but it's a more of a monitor. They've just come out with, I think it's called TwitchView, and we're going to have some competitive answers to that. But it's just being released, just got FDA approval. So we have a great system at a great value, and theirs requires a cable, a disposable that costs $20 every time you use it. Ours has virtually no cost with the use, so we have a huge value opportunity. Does anybody else have any questions with regards to selling the Stimpod NMS 450 or anything about neuromuscular blocking agents?
Hey, Kevin, real quick, two quick things. You may have done this recently, but for the new reps as well, the quality and quantity of the endorsements that we've had for Stimpod or for quantitative train-of-4 monitoring are really profound. Can you please make sure to send all those endorsements out to the different reps? And then secondly, I know we have an EMR cable and we're working on EMR compatibility. How do you want us to respond when they're asking, if a client asks if we can connect to their EMR?
If the question of the electrical medical record compatibility, where will it communicate to a monitor or to a machine, we have a video of our prototype that I can send out to a customer. We're anticipating the cable and the technology to be available probably in October. We'll probably introduce it at the ASA in San Francisco. So it definitely will be available by the first part of 2019. And all of our devices are generally upgradable. So we can upgrade the software. So if they buy a Stimpod now and they want to have it communicate to their EMR next year, that is possible. The only thing, the difference would be they'd probably have to buy the cable, and there might be a software upgrade. So in general, you want to page through this catalog. You get to this section of the catalog where it says quantitative train of 4 monitoring, and you would just ask the your anesthesia provider or anesthesia tech or chief of anesthesia, how are your clinicians now monitoring their paralytics? And don't say anything there and see what they say. And then ask, would you like to evaluate a quantitative train of 4 monitor that requires no calibration whatsoever and can be set up super easy? And hopefully they'll say, yes, we'd like to try that. They try one of these. It's also nice because you can actually go in the OR with them. You can dress out, use it. You can move from room to room and test various patients that are at various levels of paralytic. And once again, you don't have to calibrate it. So it can be a relatively productive morning where you can go from room to room and clinician to clinician and let them experience how it works. And then while you're doing that, you can observe what other things they're using and what kind of absorbent they're using, what kind of nasal cannula they're using, that kind of thing, and build some rapport with that customer so you hopefully can sell it. So once again, you don't all need a Stimpod to carry around in your car, but if you're interested, we'll provide you with one. So we're not against providing you with one, but what we ideally want you to do is show this catalog, talk about the technology, and ask if they'd like to evaluate it. Okay? I'll mention one other thing that's kind of a question. You'll hear about neuromuscular blocks and neuromuscular blocking agents. They are two completely different things. The Stimpod 450 has capability for locating nerves for a regional block. And a regional block would be, let's say you're going to do a wrist surgery on me, and they might do an interscaling block where they go in with a nerve stimulator or ultrasound. They'll go in with a needle to the nerve right there that supports the whole arm, and they'll inject lidocaine or anesthetic there. And then I could literally do surgery and almost watch it while they're doing it. That's called a regional nerve block. And people get nerve blocks confused with neuromuscular blocking agents. So nerve block is when you use a needle to and inject anesthetic at the nerve, and thus you don't have to use as much general anesthetic to do that surgery. Whereas what we're doing is we're delivering a neuromuscular blocking agent, which is a drug, that paralyzes the patient completely to the point where they can't breathe and thus have to be put on a ventilator. And that's where the Stimpod 450 can be used. It can be used during induction to measure that the patient is totally paralyzed, or it can be used during maintenance to ideally titrate the drugs and when they need more rocuronium. And then finally, its best asset is when it's used to verify that the patient has reversed and that they will be safe to extubate, and thus they'll go to the PACU at the appropriate level with minimal paralytic on board, and then they won't have to be reintubated or have breathing problems. Okay? So that's basically, I will send out information as Mike requested. I might ask if there probably is other questions. We have a couple minutes. If you have any other questions, let me know.
Hi, Kevin.
Yes, sir.
This is Tony in Portland. I'm having problems with the accelerator or accelerometer strap coming off during the case. and that's happening quite a bit. Is there something we're doing wrong when we're putting that on?
No, I would say that American thumbs tend to be larger than maybe the world's, and we are coming out with a accelerometer strap that's going to be a little bit longer. So that would be my guess, is that maybe they can, if that is a problem, they don't even need to use the strap. They can just use tape if they needed to, or if they use it and it's barely fitting on, I would say they could use tape once again. But I don't think, I'm pulling it on right now and it's pretty tight. I'm not sure what the issue is there, if it's length, but we are coming out with a longer one. We can talk about that offline also. Any other questions?